लाइव है, बोलो थोड़ा रुकेगा।
2 मिनट रुक जाओ।
अच्छा बस बोलो ठीक है, अच्छा कोई बात नहीं, बस हो गया। ठीक है कोई बात नहीं, बोलो ठीक है। Hi guys, welcome to the session. If I'm audible and visible, please send your thumbs up in the chat box. Okay, great. So we are going to start. Welcome to the session. welcome guys, welcome. So we are going to start. Now first, what is the most common cause of bloody nipple discharge? We will be really very quick here. Yes, so tell me the most common cause of bloody nipple discharge. You know, it is duct papilloma. So most common cause of bloody nipple discharge, that is duct papilloma. And what is the treatment of choice for duct papilloma? All of you know. The treatment of choice for duct papilloma, that is microdocectomy. What is the treatment of choice? It is microdocectomy. Microdocectomy. And if patient is having duct ectasia, what is the treatment of choice? Hadfield's operation. Yes, Hadfield's operation. So patients who are having duct ectasia, the treatment of choice is Hadfield's operation. Next, peau d'orange. You know what is the stage in peau d'orange? The stage, it is T4B. Stage is T4B, and it is because of lymphatic permeation by tumor cells. There is involvement of subdermal lymphatics. So due to involvement of subdermal lymphatics, it is because of involvement of subdermal lymphatics. Clear? So there is lymphatic permeation by tumor cells, that is peau d'orange. Next question for all of you. What is the most common site of metastasis in CA breast as well as CA prostate? Tell me. In CA breast as well as CA prostate, what is the most common site of metastasis? All of you know it's bone. And in bone, which vertebra? It's lumbar vertebra. So it's bone, and which vertebra? You know, it's lumbar vertebra. So it is bone. Everybody is correct. Bone, lumbar vertebra. Most common organism responsible for breast abscess, Staph aureus. What will be the clinical scenario? Patient will be having fever. There will be lactating female. It will be the first baby. So lactating female. Primary. There is fever, engorgement of breast. There is tenderness, and organism is Staph aureus. What is the treatment of choice for breast abscess? All of you know, IND plus antibiotics. So it is Staph aureus. And this question was asked many times in exam. What is the first line agent for Staph aureus, guys? Tell me. The first line agent, that is cloxacillin. It is cloxacillin, also known as dicloxacillin. Okay, cloxacillin, dicloxa. Guys, I will be teaching you the clinical question also. So cloxacillin, dicloxacillin, clinical scenario, lactating female, first baby, primary, tenderness in the breast, there is pain and there is fever. Treatment of choice for cystosarcoma phyllodes. Affected breast will be massively enlarged, bosculated appearance. It is type of a sarcoma. There is hematogenous spread. Most common site of metastasis is lungs. And you know, treatment of choice, we are going for simple mastectomy. So treatment of choice, simple mastectomy. We are going for simple mastectomy. Clear? Now see the next one. What is most common solitary thyroid nodule? You know, it is colloid goiter. Colloid goiter. And what is the investigation of choice for diagnosis of solitary thyroid nodule? Investigation of choice, you know, it is FNAC. That is FNAC. What is the first investigation done? And the first investigation done, that is thyroid function test. Next question. What is the most common location of thyroglossal cyst? What is the presentation in thyroglossal cyst? Tell me. Midline swelling, located is in upper part of neck. It moves with deglutition and moves up on protrusion of tongue. What is the treatment of choice? Cyst trunk operation. Most common location, you know, subhyoid. So most common location, subhyoid. Treatment of choice, that is cyst trunk operation. Treatment of choice, cyst trunk operation. And all of you know that there is increased risk of one malignancy. Which malignancy, guys, tell me? Papillary carcinoma. So there is increased risk of one malignancy. Which malignancy? All of you know, it is papillary carcinoma. Papillary carcinoma, retrosternal goiter, when more than 50% of thyroid tissue is located below the opening of thoracic cage. How much? More than 50% of thyroid tissue. Clinical presentation, it is going to compress the midline structures. So there can be dyspnea, dysphagia, hoarseness of voice, Pemberton sign is positive, thyroidectomy should be done. And for thyroidectomy, what kind of incision? Tell me. Cervical. So incision for retrosternal goiter, we are going to perform total thyroidectomy. And what kind of incision, guys, tell me? We are going to perform cervical incision. Usually cervical incision. So thyroidectomy is done, cervical incision is given. Next question, autoantibody for Hashimoto's. Autoantibody for Hashimoto's, all of you know, it is anti-TPO. So anti-thyroid peroxidase. What will be the clinical scenario? Most common cause of hypothyroidism worldwide. So what it is? Hashimoto's thyroiditis. How to remember Hashimoto? See, first letter is H. H means patient will be having Hurdle cells. Remember, H means Hurdle cells. Second letter is AS. AS means patient will be having Ashkenazi cells. Hurdle cells, Ashkenazi. Clear? So there is Hurdle cells, Ashkenazi cells. After that, I means infiltration of lymphocytes. You know, there is infiltration of lymphocytes. Clear? Infiltration of lymphocytes. And all of you know what? There is antibody, that is TO. TO means TPO. TO, that is TPO. It is going to increase the risk of two malignancy, you know. One is papillary carcinoma and another is thyroid lymphoma. So increased risk of papillary carcinoma. Okay, guys. So it is papillary carcinoma, increased risk, and thyroid lymphoma. Thyroid lymphoma, it leads to permanent hypothyroidism. Since it leads to permanent hypothyroidism, that's why for lifelong you have to give levothyroxine. Another question which we are expecting, that is Graves. In Graves disease, can you tell me, in Graves disease, what is autoantibody? It is LATS. What is LATS? Long acting thyroid stimulator. And this is against which receptor, guys? Tell me. This is against TSH receptor. So it is LATS against which receptor? LATS against TSH receptor. Clear? Clinical receptor. Next, orphan NEI nuclei. So what will be the clinical presentation in orphan NEI nuclei? Tell me. Midline swelling in anterior part of neck. There will be a mass. When FNAC is done, obviously there is orphan NEI nuclei. It is papillary carcinoma thyroid. Most common route of spread, lymphatic. Easy. And what is the treatment of choice? We go for total thyroidectomy plus removal of enlarged central group of lymph nodes plus minus MRND. So orphan NEI nuclei, papillary carcinoma thyroid. Okay. What is the most commonly injured nerve during thyroidectomy? Tell me. It is external branch of superior laryngeal nerve. External branch of superior laryngeal nerve. What is the clinical scenario? If a patient is going to sing, if external branch of superior laryngeal nerve is injured, patient is not able to elevate the pitch. So patient cannot sing. This question was asked in FMGE exam this year in January. After total thyroidectomy, patient was not able to sing because this nerve is responsible for elevating the pitch. And if there is injury of recurrent laryngeal nerve, all of you know, because of injury of recurrent laryngeal nerve, what will happen? Hoarseness of voice. There is hoarseness of voice. Hoarseness of voice. Okay. Next question. Question will be asked. A hyperthyroid patient, clinical scenario. Hyperthyroid patient was taken for surgery. During surgery, patient developed thyrotoxic crisis. So that is intraoperative thyrotoxic crisis. You didn't make this patient euthyroid. So what is the cause? It is inadequate preoperative preparation. What's the cause? It is because of inadequate. This is because of inadequate preoperative preparation. This is because of inadequate preoperative preparation. Easy. Okay. Next, most common cause of primary hyperparathyroidism. And you know, patient is having parathyroid adenoma. It is multiple or solitary? Solitary. In superior parathyroid or inferior parathyroid? Inferior. So these patients are having solitary parathyroid adenoma. Located into which parathyroid? Tell me. It is inferior. Which parathyroid? Inferior. What will be the presentation? Obviously hyperparathyroidism. So patient will be having signs and symptoms of hypercalcemia. Next, famous question. If a patient is having parathyroid adenoma, what is the most accurate modality for localization? All of you know, cysta-MEB scan. That is cysta-MEB scan. Clear? So it is cysta-MEB scan. Next, what is the best test for diagnosis of pheochromocytoma? Best test, guys, best test. मैं बता रहा हूँ आपको 100% चांस है. We are expecting one question out of pheochromocytoma. Clear? The best test, it is plasma, fractionated plasma metanephrines. Remember, that is fractionated plasma metanephrines. So this is fractionated plasma metanephrines. No, it is not 24 hours urinary. It is fractionated plasma metanephrines. Guys, it is best test. Remember, it's best. It is best. Clear? So, best test for diagnosis of pheochromocytoma, fractionated plasma metanephrines. Next, what is the most common site of metastasis in older children having neuroblastoma? Long bones. Long bones. Lung metastasis is rare. So it is long bones. Next, what is the most common functional pancreatic neuroendocrine tumor in men 1? And all of you know, it is gastrinoma followed by insulinoma. It is functional pancreatic neuroendocrine tumor. So this is gastrinoma. So that's gastrinoma followed by insulinoma. It is gastrinoma followed by insulinoma. Clear? Next question. Diagnosis of amoebic liver abscess. Let me tell you the diagnostic clue. Amoebic liver abscess is called by entamoeba histolytica. Patient belongs to low socioeconomic status in developing countries. What will be the problem? Since there is infection of entamoeba histolytica, the clinical scenario, these people will be having history suggestive of diarrhea, dysentery. So any patient who is having history of diarrhea, patients who are having history of dysentery. So diarrhea, dysentery, patient belongs to developing countries, relatively fever is less common. It is not very high grade. Clear? These are the clues. When you suspect amoebic liver abscess, diagnosis is confirmed by serology. So all of you know, it is confirmed by serology. Serology. What are the other questions related to amoeba? There is amoebic colitis. There is flask-shaped ulcer, amoeboma. Anchovy sauce appearance is there. What kind of collection is there? Reddish brown or chocolate brown, that is known as anchovy sauce appearance. Clear? Next. What is the most preferred modality? Anatomically and surgically appropriate hydrated cyst. So most preferred for anatomically and surgically appropriate lesions in hydrated cyst. All of you know, pair. Can you tell me the pair full form? Puncture, aspiration of content, instillation of scolicidal agent and reaspiration. How much saline we are using as scolicidal agent? 20% saline. So we are using hypertonic saline, percentage is 20% saline. Okay. Next question guys, tell me, what is the most common malignancy of liver? It is metastasis or secondaries. What is the most common primary malignancy of liver? HCC. Most common primary malignancy of liver in children, hepatoblastoma. And most common benign tumor of liver, that is hemangioma. Okay. Next, this question is expected in exam. There is central stellate scar and spoke wheel appearance. I am waiting for the reply. Tell me. Benign tumor, central stellate scar, spoke wheel appearance. All of you know, it is seen in FNH. What is the full form of FNH? That is focal nodular hyperplasia. So FNH, this is focal nodular hyperplasia. Easy. Next, liver tumor. This question will be asked in exam. Liver tumor which is relatively more common in females, young females, not associated with cirrhosis, not associated with hepatitis B virus, hepatitis C virus infection. Alpha fetoprotein is normal, and see the tumor marker, neurotensin and B12 binding globulin. Tell me which one. Neurotensin, B12 binding globulin. This is fibrolamellar variant. You know, this is fibrolamellar variant of HCC. So it is fibrolamellar variant of HCC. I repeat, I'm going to repeat. More common in females, relatively young, not associated with cirrhosis, not associated with hepatitis B virus, hepatitis C virus. Condition of liver is relatively good. Next, guys, tell me, investigation of choice for hepatoblastoma. You know, for most of liver tumors, most of kidney tumors, investigation of choice for diagnosis, it is CCT. Exception, Wilms tumor, hemangioma, MRI. And if children are having tumor, hepatoblastoma, confirm it with biopsy. So here we confirm it with biopsy. Next, there is one segment of liver which is spared in Budd-Chiari syndrome caused by hepatic vein thrombosis. Why? This liver segment is having its venous drainage directly into IVC. Tell me which segment? It is caudate lobe. That's why in patients of Budd-Chiari syndrome, almost whole liver is atrophied, but caudate lobe is hypertrophied, and this is known as central hotspot sign. So caudate lobe is spared. Next question. Guys, see here, creatinine, bilirubin, INR, CBI, it is component of MELD score. What is MELD score? Model for end-stage liver disease. So this is MELD score, model for end-stage liver disease. Second is PELD score, and third is CTP score, which is asked in exam. If you insert Sengstaken-Blakemore tube to control the bleeding, especially during hematemesis, varicose bleeding, what is the most common complication? Aspiration. And that's why what should be protected before insertion? Before insertion of tube, airway should be protected. You know, airway, it should be protected before insertion. Next question, what is the most common complication of TIPS? You know what will happen? The portal blood is going directly into systemic circulation, which is high in ammonia. Since it is high in ammonia, ammonia enters into systemic circulation. That's why patient will be having hepatic encephalopathy. So most common complication, all of you know, it is encephalopathy. Encephalopathy. Next, what is the preferred vein for insertion of peritoneovenous shunt? In patients of refractory ascites, you insert peritoneovenous shunt. Which vein? Internal jugular vein. Second is superior vena cava. So preferred right internal jugular vein. Not given in the option, mark superior vena cava. Next question. Most common cause of pre-sinusoidal intrahepatic portal hypertension, you know, it is cystosomiasis. So you know the answer? This is cystosomiasis. Okay, next question. Cholesterol gallstones are made up of, what is the composition, guys? Tell me. Crystalline cholesterol monohydrate. This is crystalline cholesterol monohydrate. Cholesterol monohydrate. It is monohydrate. Next, tell me, what is the most common type of gallstone worldwide? It is mixed. If mixed is not given in the option, in that case mark cholesterol. Cholesterol. What is the most common type of gallstone in Asian countries or Asian population? It is pigmented. Next question. What is the gold standard investigation for diagnosis of acute cholecystitis? Tell me. HIDA scan. Hepatobiliary immunodiacetic acid scan. And if question is asked, investigation of choice for cholecystitis, tell me. Investigation of choice for diagnosis, that is ultrasound. So investigation of choice, it is ultrasound, gold standard HIDA scan. Now you tell me, there is gallstone ileus. Which triad is positive? Rigler's. What is Rigler's triad? Tell me. Rigler's triad, there is small bowel obstruction, pneumobilia, ectopic gallstones, right? And what is the most common site of fistula between gallbladder and duodenum? Tell me. cholecystoduodenal. Name of fistula, this is cholecystoduodenal. So it is cholecystoduodenal. Okay. Next, very easy. It was asked multiple times. Diamond ring sign, comet tail artifacts, V-shaped artifacts, all these are seen in adenomyomatosis. So all these are seen in adenomyomatosis. Next, in carcinoma gallbladder, in N1, how many lymph nodes are involved? 1, 2, 3. And in N2, 4 or more. N1, 1, 2, 3, N2, 4 or more. Next, easiest question, which organ is having maximum absorptive capacity per unit surface area? Tell me, jejunum or gallbladder? Maximum absorptive capacity per unit surface area. Tell me, jejunum or gallbladder? Obviously, gallbladder. And if the question is asked maximum absorptive capacity, then go for jejunum. Maximum absorptive capacity, jejunum. Maximum absorptive capacity per unit surface area, then it's gallbladder. Gallbladder. Next, what is the most common type of choledochal cyst? 1, followed by type 4, followed by type 3. So what is this? How to remember? 1, 4, 3. 1, 4, 3. What is the name of classification? Todani modification of Alonso-Ledge classification. Next question. What is the maximum size of CBD stone removed by ERCP? ESWL is going to remove the kidney stone size 2 centimeter. CBD stone 1.5 centimeter. So maximum size of CBD stone removed by ERCP, that is 1.5 centimeter. Next, what is Reynolds pentad? You know, in cholangitis there is a triad. Charcot's triad, pain, jaundice, fever. So Reynolds pentad, apart from pain, jaundice, fever, Charcot's triad, there is shock plus mental status changes. Shock plus mental status changes. Okay, so shock plus mental status changes. Next question, according to Bismuth classification, Bismuth, hilar stricture with intact confluence. Now see here, whenever common hepatic duct stump is more than 2 centimeter, it's 1. Less than 2 centimeter, type 2. Hilar stricture with intact confluence, type 3. Hilar stricture with destroyed confluence, type 4. Stricture involving aberrant right sectoral duct with or without stricture of common hepatic duct, type 5. So this one, intact confluence, remember, it's type 3. I'm telling you 100% chances are there. We are going to expect one question out of Strasbourg classification, Bismuth classification. Remember, Strasbourg, Bismuth. Next, pruned tree appearance because of selective destruction of terminal intrahepatic branches of the bile duct. It is seen in primary sclerosing cholangitis. Two things you have to remember. It is more common in males. Clear? There is involvement of both intrahepatic bile duct, extrahepatic bile duct, and that's why here treatment of choice is liver transplantation. Another point, smoking is protective. Here, smoking, all of you know, it is protective in this patient. Next, pruritus precedes jaundice. There is only one condition where itching comes first. In most of other conditions, patient is having jaundice. After 1 month, 2 months, patient is having itching. But pruritus precedes jaundice in one condition. Which one? Primary biliary cirrhosis. What will be the clinical scenario? Female which is obese, she will be having itching, she will be having fatigue and autoantibody. Which one? Anti-mitochondrial. So what is the name of autoantibody? That is anti-mitochondrial. Anti-mitochondrial autoantibody. Next, hilar cholangiocarcinoma, you know, Klatskin tumor. What is the clinical scenario of hilar cholangiocarcinoma? Obviously, patient will be having obstructive jaundice, there is weight loss. Usually, gallbladder is non-palpable. Hilar cholangiocarcinoma. Next, most common congenital anomaly of pancreas. Tell me, pancreas divisum. In pancreas divisum, there is divided drainage. Right? Dorsal part of pancreas drained by accessory duct of Santorini, and main ventral part it is drained by duct of Wirsung. Next, annular pancreas, there is ring around second part of duodenum. That's why what is the treatment of choice? Perform DD followed by DJ. So what is DD, guys? Tell me DD. DD followed by DJ. DD, that is duodenostomy followed by duodenojejunectomy. So DD followed by DJ. Next, most common cause of death in acute pancreatitis within 2 weeks of hospitalization. Multiple organ failure. What's that? MODS. All of you know the full form, multi-organ dysfunction syndrome. And if patient is going to die after 2 weeks of hospitalization, it is sepsis. Next, what is the investigation of choice for diagnosis? In acute pancreatitis, CCT. And you know, what is the best time to do CT? After 72 hours, tell me why. It should be done after 72 hours, tell me why. Because CT is mainly done for complications. Complications usually take 72 hours to develop. So that's why best time to do CT after 72 hours. Next. In Bishop score, blood urea nitrogen elevation should be more than 25 milligram per deciliter. Bishop, full form. Bedside index for severity of acute pancreatitis. There is blood urea nitrogen, impaired mental status, SIRS, age more than 60, P pleural effusion. How much should be the score? More than equal to 3. Patient is having severe acute pancreatitis. SIRS, systemic inflammatory response syndrome, heart rate should be more than 90. Next, QSOFA, quick sequential organ failure assessment. What are the components? Respiratory rate more than equal to 22 per minute, systolic blood pressure less than equal to 100 mmHg, and altered mental status. So respiratory rate, how much? More than equal to 22 per minute. Gold standard investigation in chronic pancreatitis. You know, there is one investigation which is both diagnostic and therapeutic. And what's that? ERCP. ERCP, it is gold standard. Why? Because it is diagnostic and therapeutic. Easy. Next question. Central sunburst calcification. This was asked multiple times on CCT. Central sunburst calcification. Tell me, serous cyst adenoma. Seen in serous cyst adenoma. Okay. Next, both amylase as well as CEA. Amylase means patient is having pancreatitis. CEA means it is pre-malignant. It is raised in IPMN. What is the full form? Intraductal papillary mucinous neoplasm. IPMN. Okay. Next, what is the most common gene mutation, guys? Tell me. Most common gene mutation in carcinoma pancreas, KRAS followed by P16. KRAS followed by P16, and the same mutation is also seen in cholangiocarcinoma. In carcinoma pancreas, cholangiocarcinoma, most common mutation KRAS followed by P16. One question, patient is having carcinoma pancreas with waxing and waning of jaundice with melena. Tell me which type. Type of carcinoma pancreas, waxing and waning of jaundice with melena, typically seen in ampullary carcinoma. This is typically seen in ampullary carcinoma. इसमें jaundice घटता बढ़ता रहता है. There is melena also. Every 2 to 3 months, not seen in all patients, only seen in 1/3 of the patients. 1/3. Next, very easy. Most common complication of pancreaticoduodenectomy. It is delayed gastric emptying. This is Whipple's procedure. So there is delayed gastric emptying. Delayed gastric emptying. Okay. Next, gold standard investigation for insulinoma. Tell me, you have to confirm the diagnosis. How to confirm? 72 hours fasting. That is gold standard. 72 hours fasting. And what is the best technique for localization? You know, insulinomas are not going to express somatostatin receptors. That's why SRS, it is useless. So we are going for intraoperative endoscopic ultrasound with manual palpation. Rest all neuroendocrine tumors, including carcinoid tumors, they are going to express somatostatin receptors, and that's why investigation of choice is SRS. But here, endoscopic ultrasound. Next, what is the most common site of gastrinoma? First part of duodenum, D1. It is associated with MEN1. In MEN1 also, most common site of gastrinoma, D1. Next question, what is the most common symptom of glucagonoma? You know, necrolytic erythema migrans. This is what? This is necrolytic erythema migrans. Erythema migrans. Another question which is asked, it is known as 4D syndrome. Can you tell me what is 4D syndrome? So this is known as 4D syndrome. D, diabetes. D, dermatitis. D, DVT. D, depression. Diabetes, dermatitis, DVT, depression. Most common symptom, dermatitis. Special type of dermatitis, what's the name? Necrolytic erythema migrans. Easy. Next, what is the location of defect in Bogdalek hernia? It is left posterolateral. What is the location of defect in Morgagni hernia? Left anteromedial. So this is left posterolateral. Next, investigation of choice for diagnosis of GERD, it is endoscopy. And if you see the gold standard investigation, gold standard, yes, that is 24 hours ambulatory pH monitoring. 24 hours ambulatory pH monitoring, that's the gold standard. It's pH monitoring. Okay? Bird beak appearance, pencil tip appearance, rat tail appearance on barium enema, all these achalasia cardia. Achalasia cardia, what will be the clinical scenario in achalasia cardia? Remember, there will be dysphagia more to L, liquids in comparison to solids. So dysphagia more to liquids in comparison to solid. Apart from dysphagia, patient will be having weight loss. So clinical scenario, patient will be having dysphagia more to liquids followed by solids. She will be having weight loss. You know, it is going to increase the risk of squamous cell carcinoma. Most common complication because of aspiration is lung abscess. Corkscrew or rosary bead appearance, it is seen in diffuse esophageal spasm. It is because of tertiary contraction. What kind of clinical scenario? Patient will be having left-sided chest pain and it mimics angina. Patient will be referred to cardiologist. Cardiovascular profile will be normal. You are going for barium swallow. What kind of appearance? Corkscrew or rosary bead appearance. Another clinical scenario based question, motility disorders, they will ask you what is the investigation of choice? Manometry. So in motility disorders of esophagus, what we do? Investigation of choice is manometry. Okay. Now see the next one, very easy. Most common symptom of Zenker's diverticulum. Diverticulum compresses the esophagus itself. What? Dysphagia. What kind of clinical scenario will be there? Elderly male, diabetic. What happens? He is having lung abscess. Lung abscess, clear. Patient will be having regurgitation. There is halitosis, bad breath because fermentation of food is there. Barium swallow picture will be given and they will be asking treatment. We are going for cricopharyngeal myotomy plus diverticulopexy. Size of diverticula more than 5 cm, go for diverticulectomy. Another procedure, we can go for Dohel-Mann's procedure. What is Dohel-Mann's? We can go for diverticuloesophagostomy. So that is Dohel-Mann's procedure. Next, investigation of choice for staging of carcinoma esophagus and stomach. It is same, endoscopic ultrasound. Investigation of choice for diagnosis, it is same, endoscopy plus biopsy. If you perform esophagectomy, you have to perform the replacement of esophagus with a conduit. And what is the preferred conduit? Stomach. Not available, after that left colon. It's not available, after that jejunum. There is another question which examiners are asking nowadays. Stomach is based on which artery? Right gastric artery plus right gastroepiploic artery. Based on right gastric plus right gastroepiploic artery. Next question, macular striate. What is macular striate? Thoracic pain, vomiting, cervical subcutaneous emphysema. It is positive in spontaneous esophageal perforation. What's the name? Boerhaave. So this is known as Boerhaave syndrome. It is seen in Boerhaave syndrome. So macular striate positive in Boerhaave syndrome. Okay. Next, treatment of choice in chronic or intractable duodenal ulcer, that is highly selective vagotomy. HSV, highly selective vagotomy. After that, what is the most common metabolic complication of gastrectomy? Iron deficiency anemia. iron deficiency anemia. And when more than 50% of stomach is removed, more than 50% stomach is removed. If more than 50% of stomach is removed, then vitamin B12 deficiency. So patient will be having megaloblastic anemia. What kind of manifestation will be there in exam? Yes, signs and symptoms of neuropathy, abnormal sensation. तो इस पेशेंट को क्या होता है बॉडी में सेंसेशंस होती हैं. कैसी सेंसेशंस? जैसे सरसराहट, थरथराहट, फरफराहट, चिलमिलाहट, कुलबुलाहट. और उसके लिए पेशेंट को क्या लेना पड़ेगा? बोलिए पिल्स. Which pills? B12. Got it? These two questions are trending because of the reel. Most common metabolic complication, iron deficiency anemia, more than 50% of stomach is removed, vitamin B12 deficiency, megaloblastic anemia. Okay, next. According to Forest classification, what is this non-bleeding visible vessel? Tell me. So if there is non-bleeding visible vessel, this is 2A. What is type 1? Active pulsatile bleeding, 1A. Oozing, 1B. Non-bleeding visible vessel, 2A. Adherent clot, 2B. Black dot, 2C. Clean base, 3. So it is 2A. Next, what is the most common artery responsible for bleeding in Mallory-Weiss syndrome? Left gastric artery. And what is the most common artery responsible for bleeding duodenal ulcer? Gastroduodenal. Remember, bleeding duodenal ulcer, artery is gastroduodenal. Mallory-Weiss syndrome, artery is left gastric artery. Next, tell me, if any bleeding disorder is there in the stomach, Mallory-Weiss tear, Dialfoy's lesion, watermelon stomach, go and visualize. Endoscopy. So what is the investigation of choice for diagnosis of watermelon stomach? Endoscopy. Since there is vascular ectasia, confirm it with biopsy. So it is endoscopy plus biopsy. What kind of appearance on endoscopy? Parallel stripes of vessels near antrum. It looks like watermelon. Next, what is Crookenberg tumor? Involvement of bilateral ovary. What is the most common route? It is retrograde lymphatic. So most common route, it is retrograde lymphatic. So route is retrograde lymphatic. What are the other routes? It can be because of transcoelomic transperitoneal. It can be because of hematogenous spread, but mainly retrograde lymphatic. Next, unresectable gist. Downstage the tumor. What is the drug of choice? All of you know. Imatinib. Second line, sunitinib. Third line, regorafenib. Okay, and if it is resectable tumor, in that case we go for wedge shaped excision with 2 cm margin. Next, what kind of dyselectrolytemia is there in infantile hypertrophic pyloric stenosis? I am telling you, we are expecting this question. We are expecting this question in exam. So there is hypokalemia. There is hypochloremia. Patient will be having metabolic acidosis or alkalosis. Tell me, acid loss is there, so metabolic alkalosis with paradoxical aciduria. Alkalosis with paradoxical aciduria. I am telling you, this is very, very important. And here, what is the fluid of choice? Fluid of choice is normal saline. Remember, fluid of choice, normal saline. What will be the clinical scenario? After 4 to 6 weeks of birth, usually a male child having multiple episodes of non-bilious vomiting, direction of peristalsis left to right, ultrasound is investigation of choice, give normal saline, treatment of choice, Ramsted's Frieded pyloromyotomy. Ramsted's Frieded pyloromyotomy. So it is Ramsted's Frieded pyloromyotomy. Easy. Next, most common site of stress ulcer. You know that acid is being produced by which cells? Parietal cells, and it is maximum concentration of parietal cell is seen in fundus. So what is the most common site of stress ulcer? Stomach. Which part? Fundus, followed by body, followed by antrum, followed by pylorus. Fundus, body, antrum, pylorus. This question was asked multiple times. Diagnostic criteria for SBP. SBP means spontaneous bacterial peritonitis. First, monomicrobial growth. If you do paracentesis, single organism should be responsible. So there should be monomicrobial growth. And another thing, what? Neutrophils more than 250. There should be neutrophils number more than 250 per mm cube. Neutrophils more than 250 per mm cube. Okay? If patient is having perforation peritonitis, patient is in the state of shock. First resuscitate the patient. How? Give IV fluids. And after resuscitation, then only take the patient for laparotomy. So what we do here? Exploratory laparotomy. First give IV fluids, followed by exploratory laparotomy. So it is IV fluids followed by exploratory laparotomy. Okay. Next, what is the most common site of intraperitoneal abscess? All of you know, pelvis. Overall, most common site is pelvis. Imagine patient is in recumbent position, then it's hepatomorusan pouch. Patient is in upright posture, it's pelvis. Ambulatory patient, pelvis. Overall, pelvis. What is the triad of mesenteric cyst? Tilloch's triad. Can you tell me what are the components of Tilloch's triad? Tilloch's triad. So there is soft fluctuant swelling in periumbilical region, moving perpendicular to attachment of mesentery. There is zone of hyperesonance around the swelling. What is the most common type of mesenteric cyst? Tell me. Chylolymphatic. It is chylolymphatic, followed by enterogenous. Another question which is asked, what is the treatment of choice? For chylolymphatic cyst, since there is no shared wall, no shared vascular supply, I can go for enucleation. So we can go for enucleation, and for enterogenous cyst, what we do? We go for resection plus anastomosis. So we go for resection plus anastomosis. RA. Next question. What is the most common cause of small bowel obstruction? Adhesions. Most common cause of large bowel obstruction? Malignancy. Tell me which malignancy. What is the location of malignancy, guys? Tell me. The site is rectum followed by sigmoid. It is rectum followed by sigmoid. Okay. Next. Claw sign, coiled spring sign. It is typically seen in which condition? Intussusception. Intussusception. What are the other clinical questions in intussusception? Obviously, child will be in 6 to 10 months of age. Patient will be having signs and symptoms of obstruction, colicky pain, multiple episodes of bilious vomiting. After 3 to 4 episodes of attack, the child is going to pass little amount of stool mixed with blood, known as red currant jelly appearance. There is sausage shaped mass. There is empty right iliac fossa, known as sign of dance. How to treat it? Enema is diagnostic and therapeutic. So we give air enema. Air enema is preferred over barium enema. Okay? So claw sign, coiled spring sign. Next, coffee bean sign, omega sign, bent inner tube sign, all these in sigmoid volvulus. What will be the clinical scenario? These patients will be having signs and symptoms of large bowel obstruction. It is more common in elderly people. Next question. Meckel's diverticulum, it is characterized by rule of 2, seen in 2% population, 2 inches in length, located 2 feet proximal to IC junction. Symptomatic patients are less than 2 years of age. And what is the ectopic mucosa? Mnemonic, GPC. All of you know the full form. G, gastric, followed by pancreatic, followed by colonic. So you can see here, it is gastric, followed by pancreatic, followed by colonic. Okay. Next, thickened and petulous IC valve, narrowed terminal ileum on barium meal follow through. This is known as inverted umbrella sign. What is the other name? Fleischner sign. So this is also known as Fleischner sign. So this is also known as inverted umbrella sign. Okay. So inverted umbrella sign, also known as Fleischner sign. Okay. Another important point. Any patient who is having enterocutaneous fistula, enterocutaneous means between bowel and skin. So if it is proximal fistula, there is higher loss of electrolytes. So which fistulas are having maximum risk of dyselectrolytemia? If it is located in duodenum, followed by jejunum, followed by ileum. So maximum risk of dyselectrolytemia is seen in which fistula? Duodenal fistula. Duodenal. There is maximum risk of dyselectrolytemia. Next, small bowel carcinoid. We are expecting one question. How to diagnose the carcinoid tumor? Tell me. In urine, you are going to estimate 5-hydroxy-indole acetic acid. How much urine sample is required? 24 hours. So here, 24 hours urinary estimation of, so it is 24 hours urinary estimation of 5-HIAA, 5-hydroxy-indole acetic acid. So it is 5-hydroxy-indole acetic acid, 5-HIAA. Clear? Next, what is the investigation of choice for diagnosis of Hirschsprung's disease? In Hirschsprung's disease, there is absence of ganglion cells, especially most common site is rectum. So what happens here? You have to look for ganglion cells. How to look for ganglion cells? Go for biopsy. So we go for rectal biopsy. Since the most common site is rectum, patient will be having signs and symptoms of large bowel obstruction. What is the clinical scenario? Just after birth, child will be having abdominal distension and there is no passage of meconium within 24 hours. So most common presentation, abdominal distension. Next, sawtooth appearance on bare minima. This kind of appearance, can you tell me? Sawtooth, all of you know, it is seen in colonic diverticulosis. Sawtooth, it is seen in colonic diverticulosis. Next, what is the treatment of choice for FAP? Remove the whole colon, remove the whole rectum. So it is total proctocolectomy. After that, you create the pouch, ileal pouch anal anastomosis. So it is total proctocolectomy plus ileal pouch anal anastomosis, and you know, same treatment is also done in ulcerative colitis. Same treatment is also done in ulcerative colitis. So total proctocolectomy plus ileal pouch anal anastomosis. Next, what is the most common extra-intestinal malignancy in HNPCC? How to remember? Mnemonic is ego. It is ego. Ego means endometrial followed by gastric followed by ovarian. Remember, this is endometrial followed by gastric followed by ovarian. So endometrial followed by gastric followed by ovarian. Ego. Next, chemotherapy regimen in colorectal cancer as well as small intestinal adenocarcinoma, FOLFOX. This is FOLFOX. So what is this FOLFOX? FOLFOX4. Fol is folinic acid or leucovorin. So this is folinic acid or leucovorin. F means 5-FU, 5-fluorouracil. Ox means oxaliplatin. This is oxaliplatin. Okay. Next question. What is the most common site of ischemic colitis? All of you know. Splenic flexure of colon. Splenic flexure of colon. And there is a typical sign. What is the typical sign? If patient is having ischemic colitis, thumb printing. Remember, there is typical sign in this, thumb printing. So you will find thumb printing. Thumb printing. Another one, if you perform CCT and there is accordion sign, that musical instrument, accordion, it is seen in pseudomembranous colitis. Pseudomembranous colitis. Clear? So accordion sign on CCT, it is seen in pseudomembranous colitis. Pseudomembranous colitis. Right? Next. Okay. Next you can see most common early complication of ileostomy. So when you create ileostomy, what happens? There is ischemia. Because of that, there can be necrosis. So most common early complication. Early complication, it is ischemia. Ischemia, or it can lead to necrosis. So it is ischemia or necrosis. Okay. What is the most common site of fistula, perforation, carcinoma in Crohn's disease? Fistula, perforation, carcinoma in Crohn's disease. Remember, it's ileum. It is ileum. We already discussed that in ulcerative colitis as well as in FAP, I can go for total proctocolectomy plus ileal pouch anal anastomosis. What is the most common complication in FAP? Adhesions leading to small bowel obstruction. But in ulcerative colitis, there is inflammation. So there is inflammation of pouch. What's the name? Pouchitis. Pouchitis. Followed by small bowel obstruction. Okay. Next question, guys, tell me, if a patient is having appendicular lump, what is the clinical scenario? 3-4 days after appendicitis, patient came to you. In right iliac fossa, there is a appendicular lump, and then question is asked, how to manage this patient? Tell me, which regimen we follow? Ochsner-Scheren regime. So this is Ochsner-Scheren regime. So these patients are followed by or managed by Ochsner-Scheren regime. In Ochsner-Scheren regime, first confirm the diagnosis by CT, give IV fluids and IV antibiotics. Vitals monitoring should be done. Majority of patients are going to improve. Continue conservative management. After 4 to 6 weeks, we are going for interval appendectomy if patient is having recurrent appendicitis. Next, muscle cutting incision. There is only one incision in appendectomy, which is muscle cutting, Rutherford-Morrison. Only one. It is Rutherford-Morrison. Rest all incisions of appendectomy are muscle splitting. So Rutherford-Morrison incision used for retrocecal appendicitis, it is muscle cutting. We are going to cut conjoint tendon, that is internal oblique plus transversus abdominis. Next, if hemorrhoidectomy is done, what is the most common complication? You know, it's pain followed by urinary retention. Clear? So it is pain followed by urinary retention. So pain followed by urinary retention. Okay. Next, if a patient is elderly and frail, patient cannot tolerate long duration surgery. So that's why preferred rectopexy, it's perineal. Perineal. It's the perineal rectopexy. How to remember? Mnemonic is PAD. PAD. So perineal, Altemus, Delorme, Thiersch. And what is abdominal? VAR, Wells, abdominal, Ripstein. So Wells and Ripstein are abdominal. Altemus, Delorme, Thiersch, these are perineal. Next, very easy. Most common type of fistula in ANO, type 1. What's that? Intersphincteric. Intersphincteric. Clear? This was asked this year in NEET PG 2025 in the form of image based question. So it is intersphincteric followed by transsphincteric followed by suprasphincteric followed by extrasphincteric. How to remember? It's extra. 1, 2, 3, 4. So most common is type 1, it's extra. 1, 2, 3, 4. What is the most common type of fissure in ANO? Site, most common site at 6 o'clock position. And you know, it is posteriorly in the midline. So it is 6 o'clock position, posteriorly in the midline. Posteriorly in midline. So 6 o'clock position, posteriorly in the midline. Next, imagine there is a resectable tumor located 6 cm from anal verge. You have sufficient margin, so you can go for LAR. What is LAR? LAR full form, this is known as low anterior resection. Okay, what's the full form, guys? This is low anterior resection. Remember, two things. From anal verge, if a tumor is located at or below 5 cm, we go for APR. What is APR? Abdominoperineal resection. If it is located more than 5 cm from anal verge, in that case we go for LAR, that is low anterior resection. Next, treatment of choice for carcinoma anal canal. Tell me, Nigro regimen. What we do in this regimen? Nigro regimen, we give chemoradiation. This is chemoradiation. Can you tell me which chemotherapy? Chemoradiation. So you know that we are giving what? 5-FU plus mitomycin C. 5-fluorouracil plus mitomycin C followed by radiotherapy. So it is chemoradiation. Next question. If you are performing splenectomy, in which patient? ITP. You are performing splenectomy in ITP. So what is the best time for platelet transfusion in patients of splenectomy? If patient is having ITP, after ligation of splenic artery. So it is after ligation of splenic artery. Okay, so it is after ligation of splenic artery. Okay, next, what is the most common complication of splenectomy? See here, you are going to injure some fibers of diaphragm, patient is having pain, so there is restricted movement of diaphragm, lungs will be collapsed. It is atelectasis. Atelectasis. What is the clinical scenario? After splenectomy, you know, atelectasis is responsible for fever. In the first 48 hours, it is non-infectious cause of fever. So atelectasis. Next, what is the most common type of hernia in both males and females? You know, indirect inguinal hernia. So this is indirect inguinal hernia in both males and females. Indirect inguinal hernia. But remember, femoral hernia is more common in females, but the most common type is indirect inguinal hernia. Next, what is the gold standard treatment for inguinal hernia? All of you know, Lichtenstein repair. This is Lichtenstein repair. Okay, next. What are the boundaries of triangle of doom? You know, boundaries of triangle of doom. Medially, there is vas deferens. Laterally, gonadal vessels, apex, deep ring, base, peritoneum, and inside there are iliac vessels. So what's the content, guys? Tell me. Iliac vessels. It is iliac vessels. Okay. What's the problem in triangle of pain? In triangle of pain, 4 nerves are there. Most commonly injured nerve, lateral cutaneous nerve of thigh. There is hernia through gap in lacunar ligament. How to remember? L for L. L is lacunar, L Logier's. It is Logier's hernia. So L Logier's, L lacunar. Easy. Next. Hernia in which posterior wall of sac is formed by viscera. It is known as sliding hernia, also known as hernia englised. Sliding hernia, also known as hernia englised. You tell me, it is most common on which side? Hernia englised. So you know that hernia englised, it is more common on left side, more common in males. Most common content is sigmoid colon. On the right side, the content is cecum. Next, omphalocele. The content is covered. 2 layers. Outside is amnion, inside is peritoneum. So here, it is covered inside by peritoneum. Peritoneum is inside. How to remember? It is inside. So pin, mnemonic is pin. Peritoneum is in. Can you see here? Pin, peritoneum is in. Treatment of choice for desmoid tumor, wide local excision. But if there is recurrent desmoid, after surgery, give radiotherapy. So recurrent desmoid tumor, surgery plus radiotherapy. It is surgery plus radiotherapy. Okay. Next question, very, very easy. Hardest renal stone, not easily broken by ESWL, cystine. Next, suppose stone is located in the ureter, especially lower ureter. How you remove it? Put the ureteroscope and remove it. It is URS. So how we remove it? URS, ureteroscopy. Imagine patient is having putty kidney. Putty, you know, दीवारों में पेंट लगवाने से पहले लगवाइए पुट्टी, और जिस कंपनी का पुट्टी लगवाइए उसी कंपनी का सीमेंट भी लगवाइए. So remember, putty and cement, both of these are related to tuberculosis, renal tuberculosis. Renal tuberculosis. Putty, cement. What is cement kidney? All of you know, calcified kidney. What is putty kidney? There is collection of cheesy material. So grossly, if you cut the kidney, there is collection of cheesy material, that is putty kidney, calcified kidney, cement kidney. You know pulsatile secondaries. Which malignancy is having pulsatile secondaries? Tell me. RCC and follicular carcinoma thyroid. So pulsatile secondaries are seen in RCC and follicular carcinoma thyroid. These are osteolytic and hypervascular. So remember, these are osteolytic and hypervascular. Follicular carcinoma thyroid, RCC. Remember, in follicular carcinoma thyroid, which bones are involved? Flat bones, most commonly thoracic vertebra, ribs, pelvis, skull. What will be the clinical scenario? They will give you skull picture and there will be osteolytic lesions. They will ask you, कौन से thyroid malignancy से आया है? Follicular. Next, most common cause of death in ADPKD, cardiovascular disorders. Cardiovascular disorder. Okay, next question. Patients who are having pelviureteric junction obstruction, PUJ obstruction, all of you know what is the gold standard treatment. This is Anderson-Hines dismembered pyeloplasty. So what is this? Anderson-Hines dismembered pyeloplasty. Anderson-Hines dismembered, it is dismembered pyeloplasty. Okay, pyeloplasty. And one famous question which is asked almost every year, IVP is there. There is adder head or cobra head appearance. Tell me, adder head or cobra head appearance किस में देखने को मिलेगा बोलिए? It is seen in uretrocele. Uretrocele. So adder head, cobra head appearance, it is seen in uretrocele. Okay. Next, most common primary bladder stone. It is because of chronic dehydration. Right? You will not hear this stone again. Name ammonium urate. Ammonium urate. Since this stone is because of chronic dehydration, it is because of chronic dehydration. This was asked in NEET PG. A patient who is having chronic laxative abuse. Patient having chronic laxative abuse. There is chronic dehydration. What is the most common type of stone seen? Ammonium urate. Clear? Next. Most common cause of bladder calcification worldwide, which is going to cause inflammation in the bladder. You know, schistosomiasis. Because of chronic inflammation going on in the bladder, it is going to increase the risk of malignancy. Which one? Squamous cell carcinoma and transitional cell carcinoma, both. Risk is more for squamous cell carcinoma. Next, imagine there is bladder rupture. You inject the dye, take the CT. This is known as CT cystography. So bladder rupture, CT cystography. CT cystography. How to differentiate bladder rupture from urethral injury? Obviously, bladder is like a balloon. If balloon is ruptured, obviously it will not be distended. So any patient who is having distended bladder, what is ruled out? Tell me. Bladder rupture. Bladder is ruptured, then also patient can pass urine. There can be hematuria. But if urethra is transected, urine will not be coming out. So if a patient is having urinary retention, blood at meatus, bladder is palpable, urethral injury. Bladder is not distended, suprapubic pain is there, difficulty in passing urine, but there is hematuria, it is bladder rupture. Most common site of CA bladder, tell me. Trigone, which wall? It is posterolateral wall of trigone. Posterolateral wall of trigone. Trigone. What is the symptom? Hematuria, painless gross hematuria. Clinical scenario, 60 to 70 years old chronic smoker male, painless gross hematuria. Investigation of choice for diagnosis, cystoscopy plus biopsy. For staging, go for MRI. Next, chemotherapy regimen we give in metastatic carcinoma bladder, that is MVAC. Remember this, it was asked multiple times. M, methotrexate. It is methotrexate. Next, what? Vinblastine. How to remember? Bladder blastin. So it is vinblastine. Vinblastine. What else? Adriamycin. Adriamycin. What else? Cisplatin. How to remember, guys? Tell me. In bladder we give blastin. Remember, bladder blastin, not the vincristin. Blastin. What is the most important landmark in TURP? It's distal landmark. Verumontanum. Why? Because verumontanum is located just proximal to external urethral sphincter. So most important landmark, you know, it is verumontanum. This is verumontanum. What is the most common complication of TURP? Retrograde ejaculation followed by impotence followed by incontinence. So you know, retrograde ejaculation seen in 75%. Ejaculation 75%, impotence 10%. So there is impotence in 10%, incontinence less than 1%. So patients who are having incontinence, it is seen in less than 1%. Okay. Next, what is the most common site of carcinoma prostate? Most common site of carcinoma prostate, tell me. Peripheral zone or posterior lobe. So this is peripheral zone or posterior lobe. Peripheral zone or posterior lobe. Posterior lobe. Okay. Next, most common congenital malformation of urethra. Tell me. Hypospadias. It is hypospadias. Hypospadias. Next, what is the keyhole sign? If you perform prenatal ultrasound, keyhole, it is seen in posterior urethral valve. So, you know, seen in posterior urethral valve. Keyhole sign. keyhole. Okay, what is the most common site of urethral injury? Tell me, anterior urethra or posterior urethra? Posterior. In posterior urethra, what is the most commonly injured part? Membranous. In membranous, bulbomembranous or prostatomembranous is the bulbomembranous junction. I'm repeating. Most common site, membranous. It is membranous urethra, and in membranous, which junction is most commonly injured? All of you know, BM, bulbomembranous, followed by PM, prostatomembranous. So it is bulbomembranous followed by prostatomembranous. Easy. Next, if a patient is having carcinoma penis and circumcision is sufficient, usually what we do, there is squamous cell carcinoma, take 2 cm of margin. So for which malignancy circumcision is sufficient? Obviously, if malignancy is located at prepuce. So circumcision is sufficient for carcinoma penis located at, remember, prepuce. Located at prepuce. What is the big problem in carcinoma penis? There is involvement of bilateral inguinal lymph nodes. That's why there is erosion of femoral artery or femoral vessels leading to bleeding. So the most common cause of death, it's bleeding followed by sepsis. Next, investigation of choice for non-palpable undescended testis. If it is non-palpable, it is in abdomen. Go and search in abdomen. How will you search? Diagnostic laparoscopy. Search in abdomen, so perform diagnostic laparoscopy. The clinical question which is asked, if a patient is having undescended testis, what's the best age for repair? 6 months. It should not be delayed by 12 months. Surgical exploration in testicular torsion should be done within 6 hours. Remember, 6 is very important in surgery. So patient is having testicular torsion, it should be done within 6 hours. Priapism, 6 hours. If patient is having some kind of soft tissue injury, patient should come to your emergency within 6 hours if you want to do the suturing. So 6 is very important. In varicocele, location of pampiniform plexus of vein in relation to testis. What is the location? Posterior and above testis. All of you know. This is posterior and above testis. So posterior and above testis. Next, what is the most common bilateral testicular tumor? It is lymphoma. What is the most common secondary testicular tumor? Lymphoma. Most common testicular tumor in elderly? Lymphoma. Most common primary bilateral testicular tumor? Seminoma. Most radiosensitive testicular tumor? Seminoma. Next, what is the most common symptom of peripheral arterial occlusion? All of you know, it is characterized by 5 P's: pain, pallor, paresthesia, paralysis, pulselessness. In compartment syndrome, what is the late sign? Pulselessness. Which one is having worse prognosis? Paralysis. And the most common symptom? Pain. It is pain. Next, Lehret's syndrome. Lehret's syndrome means patient is having erectile dysfunction. Why patient is having erectile dysfunction? Because sufficient blood is not coming to the penis. Why sufficient blood is not coming to the penis? Because there must be reduced blood flow in both iliac, both internal iliac. So obstruction is above the level of internal iliac. It is aorto-iliac bifurcation. Aorto-iliac bifurcation. What will be the clinical scenario in this case? Tell me. Patient will be having claudication of gluteal region, thigh, calf with erectile dysfunction. Next, most commonly involved vessels in Burgess disease. It's medium and small sized vessels. Medium and small sized. Okay, how to remember? There is a mnemonic. Mnemonic is TPR. Mnemonic is TPR. What is TPR? Tell me. Tibial plantar radial. So this is tibial plantar radial. Tibial plantar radial. What kind of question we are expecting about Burgess? We are expecting ankle brachial pressure index. Intermittent claudication, ABPI should be 0.5 to 0.8. Critical limb ischemia, it should be 0.1 to 0.4. Calcification, calcified vessels more than 1.4. Here, exclusively it is seen in young male smokers age less than 40. Next, most common cause of acquired AV fistula. It is not hemodialysis, penetrating trauma. This is because of penetrating trauma. Okay, so acquired AV fistula, it is because of penetrating trauma. Clear? Next, Cutoff diameter for surgery in abdominal aortic aneurysm, it is 5.5 centimeter. So size should be more than equal to 5.5 centimeter. Next, patients who are having subclavian artery stenosis. Let me tell you, in majority of arterial disorders, the cause is atherosclerosis. Most common cause of peripheral arterial occlusion, atherosclerosis. Subclavian artery stenosis, atherosclerosis. Most common degenerative disorder of vessel, atherosclerosis. Most common cause of extracranial aneurysm, atherosclerosis. So subclavian artery stenosis cause atherosclerosis. Most common site left, where exactly? First part. So this is first part of left subclavian artery. Okay? What is the best graft for CABG? Best graft, it is Lima. Can you tell me the full form of Lima? Lima, that is left internal mammary artery. Lima, that's best. And what is the most commonly used graft? Long saphenous vein. There is another graft which we can use, radial artery. Radial artery can also be used. So best it is Lima. Most commonly used, long saphenous vein. We can use radial artery if there is patent palmar arch. Next here, what is the most common site of DVT? Calf or soleal vein. Calf or soleal vein. Next, what is the gold standard treatment for varicose vein? Nowadays, endothermal ablation. So what it is? Endothermal ablation. Clear? So that is endothermal ablation. And what are the techniques available nowadays? Nowadays, we have two techniques mainly used, EVLA and RFA. So can you tell me what is EVLA? Endovenous laser ablation. RFA, that is radio frequency ablation. Okay. Next question. Familial version of congenital lymphedema is known as Milroy's disease. This is known as Milroy's disease. Easy. And familial version of lymphedema precox is known as Meek's disease. Tell me what is the most common anterior mediastinal mass? Thymoma. And most common posterior mediastinal mass? Neurogenic tumor. Middle mediastinal mass? Cyst. So posterior mediastinal mass, it is neurogenic tumor. Neurogenic tumor. For mediastinal pathologies, what is the investigation of choice? CCT. Exception, neurogenic tumor. For neurogenic tumor, we go for MRI. Okay. Next, very easy. Imagine there is a patient of road traffic accident. At the time of presentation, patient was perfectly fine, but patient was having multiple long bone fractures. Within 48 hours, there is clouding of consciousness, there is respiratory distress, there is rashes and presence of fat globules in sputum and urine. Tell me, this is fat embolism. Fat embolism. I am going to tell you 2-3 questions which we are expecting in exam. Let me tell you, आपको पता है स्वर्ग का द्वार कहाँ से खुलता है? Tell me, the door to the heaven starts from which place in house? Bathroom. तो स्वर्ग का द्वार कहाँ से खुलता है? बाथरूम से खुलता है. History of fall in the bathroom in elderly male, subdural hematoma. Altered sensorium, स्वर्ग का द्वार खुल गया. Next, history of fall in bathroom in elderly female. She is having postmenopausal osteoporosis, fracture neck of femur. In that case, she is immobilized for long duration. After surgery, there is DVT. She expired because of pulmonary embolism. So, पहला question, history of fall in the bathroom. Elderly male, SDH. Elderly female, what will happen? Fracture neck of femur. And after that, what will happen? After that, patient will be having DVT and pulmonary embolism. Young male, road traffic accident. At the time of presentation, patient was in vegetative state, NC-CT was normal. What you suspect? Diffuse axonal injuries, investigation of choice is MRI. Young male, road traffic accident, multiple long bone fractures, rashes, clouding of consciousness, respiratory distress, fat globules in sputum and urine. What? Fat embolism. ये सारे questions expected I am telling you. So these are the questions which we are expecting. Next, X-ray PA view showing flat surface of coin, location of coin, esophagus. So if coin is in esophagus, symptom, dysphagia. Chest X-ray PA view, what you can see? Flat surface, AP and lateral view, edge. If it is in trachea, symptom is dyspnea. And on PA view, you can see the edge, lateral view, flat surface. Tell me, what is the most common symptom of carcinoma lung? Cough. This is cough. Next, degree of burn whenever there is involvement of subcutaneous fat. It is known as full thickness burn. Which degree? Third degree. Third degree. Also known as full thickness burn. So this is full thickness burn. I'm going to twist it. Imagine there is skin loss. Full thickness skin loss with involvement of subcutaneous fat. It is pressure sore or ulcer. What is the stage 3? So there is no difference between burns and pressure sore. First degree burn, epidermis involvement, pressure sore, epidermis. Second degree epidermis plus dermis, stage 2 epidermis plus dermis. Third degree epidermis plus dermis plus subcutaneous fat, and third stage same full thickness skin loss. Whenever underlying structures are involved like muscle, bone, it is 4th degree burn or stage 4 of pressure ulcer. Which question we are expecting? Sacrum will be exposed. What is the stage? Stage 4 pressure ulcer. Next, minimum urine output after adequate tissue perfusion in adults, 1 ml per minute. You can easily calculate in ml per hour, 60 ml per hour. Next question, guys, tell me, skin malignancy which is characterized by ABCDE: asymmetry, border irregularity, color variation, change in diameter more than 6 mm, E, evolution in shape, size and color. Which one? Melanoma. ABCDE seen in melanoma. Tell me, what is the most common site of keloid? Sternum. Keloid, here there is in keloid excessive scar tissue. It is going to extend beyond the original wound or incision, usually seen in darkly pigmented races. Keloid. Next, tell me, stage of pressure ulcer with full thickness skin loss extending into subcutaneous tissue. We discussed stage 3. Negative pressure used in vacuum assisted closure. How much? -125 mmHg. In which cases we are using negative pressure wound therapy? What question is expected? A seal dressing with a tubing. For applying vacuum, we are applying -125 mmHg. It is going to suck the blood over the surface. So in chronic wounds, it is going to promote the blood flow. It is going to improve the healing. Next, SDH. Tell me, subdural hematoma. It is caused by injury of cortical veins or bridging veins. Bridging veins. What kind of question is expected about EDH and SDH? Yes, the kind of hyperdense lesion. You can see here in EDH, this kind of lesion will be there. What is this? This is EDH, biconvex, and in SDH, this kind of lesion will be expected. Hyperdense lesion. What? Crescent shaped or concavo-convex. Next, some patients are coming to you after trauma or after rupture of berry aneurysm, and they are going to describe, sir, this is the worst headache of my life. Which one? It is seen in subarachnoid hemorrhage. Worst headache of life. Investigation of choice for diffuse axonal injuries. We discussed. Patient will be young. After road traffic accident, patient is in the vegetative state. INI-CET is normal. So here we are going for MRI. What is the most common site of astrocytoma? Type of astrocytoma? In children, pilocytic. What about adults, guys? Tell me. In adults, most common type of astrocytoma. Adults, GBM. What is GBM? Glioblastoma multiforme. You know that pilocytic is grade 1. It is having best prognosis. Glioblastoma multiforme, it is stage 4, having worse prognosis. So most malignant, having worse prognosis in astrocytoma. Glioblastoma multiforme. Another question is asked in the form of image based fashion. Butterfly tumor. There is central necrosis with ring-like enhancement. Dural tail sign, sunrise spicules, all of you know, seen in meningioma. So this is seen in meningioma. What is the most common brain tumor? Metastasis. What is the most common primary brain tumor? It's meningioma followed by glioma. We discussed there is central necrosis with ring-like enhancement on MRI. It is seen in glioblastoma multiforme. Another sign, since it crosses midline, it is also known as butterfly tumor. Okay, so this is also known as butterfly tumor. Next, what is the most commonly used flap for reconstruction of head and neck defects? Tell me. PMMC flap. Pectoralis major myocutaneous flap. And this pectoralis major myocutaneous flap, it is based on pectoral branches of thoracoacromial vessels. Next, if a patient is having carcinoma lip involving more than 1/3, you excise it, go for reconstruction, name of flap, Abbey Eastlanders flap, taken from superior lip. So it is based on which artery? Superior labial artery. So Abbey Eastlanders flap based on superior labial artery. Easy. So it is based on superior labial artery. Next, what is the most common salivary gland tumor? You know, pleomorphic adenoma. Pleomorphic adenoma. So most common salivary gland tumor, that is pleomorphic adenoma. Next, what is the most common site of salivary gland stone? Submandibular gland. Tell me, salivary gland stones are radiolucent or radiopaque? 80% are radiopaque. That's why, you know, 90% of kidney stones, 80% of salivary gland stones are radiopaque. In both of these cases, what is the investigation of choice? Tell me. NCCT. So for kidney stone as well as salivary gland stone, kidney stone as well as salivary gland stone, in both, investigation of choice is NCCT. Clear? It is NCCT. Next, ranula is related to, it is located in the floor of mouth just below tongue. So in relation to sublingual gland. What kind of cyst is this? It is mucus extravagation cyst. Mainly mucus extravagation. Okay, so this is mucus extravagation cyst. Liar sign. What is the problem? There is splaying of carotid because there is a tumor. Tumor here at the carotid bifurcation. What's the name? Carotid body tumor, also known as chemodectoma. So name, this is carotid body tumor. Carotid body tumor or chemodectoma. So carotid body tumor or chemodectoma. Okay. Next, what is the most common site of cystic hygroma? You have seen, it is seen in posterior triangle of neck. So neck, where exactly? Posterior triangle. So it is seen in posterior triangle of neck. Okay. So it is seen in posterior triangle of neck. Posterior triangle of neck. Next, very easy. What is the most commonly injured nerve during sentinel lymph node biopsy of breast cancer? Nowadays, this question is trending. Which nerve? Intercostobrachial nerve. Remember, this is intercostobrachial nerve. This is intercostobrachial nerve. Easy. Next question, guys, tell me, what is the most common type of soft tissue sarcoma? Liposarcoma followed by leiomyosarcoma. Liposarcoma followed by leiomyosarcoma. You know, sarcomas are having exclusively hematogenous spread. Most common site of metastasis, lungs. Investigation of choices, biopsy. To assess the extent, we go for MRI. What is the first line agent for DFSP? Dermatofibrosarcoma protuberans, imatinib. What are the other conditions where we are giving imatinib? Tell me. Imatinib is given in GIST. It is given in CML. What is the type of graft in identical twins? Isograft. Isograft, if you take tissue from your own body, it is known as autograft. If you take it from same species, that is known as homograft or allograft. Okay? If you take it from different species, that is known as xenograft or heterograft. What is the most common indication of pediatric liver transplantation? Extrahepatic biliary atresia. Pediatric liver transplantation, we go for extrahepatic biliary atresia. That's the most common indication. What is the best location for needle insertion in tension pneumothorax in adults? Fifth intercostal space. Where exactly? Remember, in anterior axillary line. It's not mid axillary. It is anterior axillary line, and in children, second intercostal space in mid clavicular line, and the ICD insertion location is same in both. Fifth intercostal space in anterior axillary line. Clear? Next, tell me, in trauma patients, packed cell, plasma and platelets are given in the ratio of 1:1:1. So this is the trauma transfusion protocol. Okay. trauma transfusion protocol. All these are given in the ratio of 1:1:1. You know, what are the components of GCS? EVM, eye opening, verbal response, best motor response. So what is the best predictor of outcome in GCS? Motor response. It is motor response. Easy. Next question. What's the ideal number of people required for log roll? Ideal 5 and minimum number 4. So ideal number 5. Ideal number 5, minimum number 4. Next, very easy. What is the first investigation done in blunt trauma abdomen patient? Fast. Doesn't matter patient is stable or unstable. Gold standard investigation. In stable patients of blunt trauma abdomen, CCT. What are the components of trauma triad of death? How to remember? Mnemonic is HCM. Hypertrophic cardiomyopathy, H. Hypothermia. After that you can see C, coagulopathy, and M, that is metabolic acidosis. So hypothermia, coagulopathy and metabolic acidosis. Can you tell me out of these, which one is the most common cause of death? Coagulopathy. So remember, coagulopathy, this is the most common cause of death. Next, how you make the diagnosis of tension pneumothorax and flail chest? Clinical. Remember, don't waste time. So it's the clinical diagnosis. If you suspect patient is having tension pneumothorax, means patient is having what? Dyspnea, tachypnea. There is absent breath sounds, and on percussion there is hyperresonance. Patient is in the state of shock, distended neck veins. Put a wide bore needle in 5th intercostal space in anterior axillary line. Next. What is the needle used for creating pneumoperitoneum? All of you know, it's Wieris needle. That is Wieris needle. Wieris needle. What is the most commonly performed bariatric surgery procedure? What you do? You remove this part of stomach. So this is known as sleeve gastrectomy. What we perform? Sleeve. So we perform sleeve gastrectomy. Okay. Plastic surgeons are using a suture in subcuticular suturing. Can you tell me what is the suture used for subcuticular suturing? Monocryl. What is the other name? It is monocryl, also known as polyglycaprone. So it is monocryl, also known as polyglycaprone. Next, we are using some suture for vascular anastomosis, for rectus sheath, for fixation of mesh in hernia. Proline. So we are using proline. Next, easy question. Suture length to wound length ratio should be 4:1. Tell me the name of this rule. What is the name of this rule? This is known as Jenkins rule. Name? This is known as Jenkins rule. What is the most common hospital acquired infection? UTI. And what is the organism responsible? E. coli followed by Klebsiella. Next, what is the best time to give prophylactic antibiotics? At induction of anesthesia or 1 hour prior to surgery? Both are same. At induction. So at induction of anesthesia or 1 hour prior to surgery. Don't mix it. 1 hour prior to surgery. So it's 1 hour prior to surgery. Next question. What is the preferred vein for TPN? All of you know is the subclavian vein followed by internal jugular vein followed by femoral vein. Suppose you go for central venous catheterization. What is the most common complication? Tell me. Catheter related sepsis. So it is catheter related sepsis. Amount of blood loss in class 2 hemorrhagic shock. How much is the loss in class 1? 0 to 15. Class 2, 15 to 30. Class 3, 30 to 40. And class 4, more than 40. More than 40%. So how to remember? 330, 440. Remember, 330, 440. So in class 2, it is 15 to 30%. Next. After road traffic accident or after trauma, there are two types of shock which are common. Most common is hypovolemic shock and there is neurogenic shock. If there is hypovolemic shock, there is hypotension and tachycardia because of sympathetic stimulation. So hypotension, tachycardia, cool clammy skin. Peripheries are cool. But what happens if there is some kind of nerve injury? What happens? There is loss of sympathetic tone. So in cases of neurogenic shock, whenever there is loss of sympathetic tone, there is pooling of blood. Massive vasodilatation is there. So these patients will be having hypotension with bradycardia, and there are warm peripheries. So hypotension, bradycardia, warm peripheries. Warm peripheries. These are seen in neurogenic shock. Seen in neurogenic shock. Neurogenic. And if there is hypotension plus tachycardia plus cold peripheries, cold peripheries. So this is seen in hypovolemic shock. Remember, so this is seen in hypovolemic shock. Hypovolemic shock. Hypovolemic shock. Okay. Next, we are using some instrument for harvesting the skin graft. Guys, tell me the name. Humby knife. Humby. It is Humby knife. Humby knife. 18 gauge cannula is green, 20 gauge cannula is pink. So 20 is pink. How to remember? At 18 years of age, you have green signal to vote. So green signal to vote at 18 years. So 18 is green, 20 is pink. What is the most commonly used Foley's catheter in males? We are using orange. And what is the size? 16 French. So in males, we are using 16 French. That is orange. Orange. What about females? We are using 14 French, green. Clear? So males we are using 16 French, females we are using 14 French. Okay guys, so these were questions, right? Best of luck. All of you are ready for the exam. Definitely you are going to crack the exam with flying colors. The whole family of PrepLadder wishes you all the very best. Best of luck. हो गया खत्म.